recorded, and the access will be provided to all of you so that you can follow and refer the notes. Ma'am, it's over to you. You're making. Dr. Shelly, I think you are on.
Hi. Hi, can you hear me? Am I audible?
Yes, ma'am, you're audible.
Okay. So, hi everyone. It's so good to see so many people on a Sunday afternoon. It's evening for us. And thank you so much, Varun, for making this platform available for us to be able to share such a important topic with so many of the august GPs. Thank you so much. And I'll just begin my presentation. Just give me 2 seconds. Hi. So, is my screen audible? Is my screen visible?
You're visible, ma'am. No, screen is not visible.
Okay. Just a second. Can you now see the screen?
Yes, ma'am, it's visible.
Visible?
Yes, ma'am, it's visible.
Okay. So, I'm Dr. Shelly Singh, and I am working as a director of Obstetrics and Gynaecology at Fortis La Femme. Today, I'll be sharing with you some of the important infertility related tests, as well as the surgeries which need to be done, which have to be done prior to the process of IVF. And these surgeries will help because these surgeries help to optimize the effects of IVF. So the results of IVF will be determined by some of these surgeries. Varun, I am not unable to.
Ma'am, just the link.
I'll just do that. 1 second.
Yeah, you can just click on the link. Let me share that again with you.
Yeah, 1 second. Yeah. Just share that with me.
Yes, ma'am. Doing that. Share that on your DM, ma'am.
Yes. Yes.
You can click on the slideshow there and then.
Yes, I will. Yes. Right. So I hope now everything is visible.
Yes, ma'am. It's visible. Perfect.
Right. Right. So first of all, as we all know, some of the causes of infertility could be some uterine problems. For instance, you could have fibroids of the uterus. There are sometimes polyps within the uterine cavity. There can sometimes be adhesions which are present inside. Then apart from that, there are some problems with the fallopian tubes, which is a fairly common condition in countries such as ours as well as yours. So basically, there will be some problems either with the fallopian tubes, uterine problems, or there could be some ovulation disorders. As we all know, ovulation is very important and is the first step in pregnancy. Now, that can happen in case of thyroid disease. It can happen in case of a very common condition these days, which is polycystic ovarian syndrome, and also in hyperprolactinemia. A lot of times, patients will not come to the gynecologist before with some of these problems like thyroid disease, PCOS, and hyperprolactinemia. In fact, they first go to the GPs whenever there is a problem, and they first go to the internal medicine people, endocrinologists, etc. And they will come across all these problems. And in these days and times, it has to be a multidisciplinary approach, which means that, a lot of times we would be referring our patients back to you to treat these thyroid diseases and also some of the endocrinal problems that can happen. Then we also have a condition which is called as endometriosis. As we all know, endometriosis is a condition where there is endometrial tissue which is present outside of the uterus, resulting in the formation of endometriotic or chocolate cysts, a lot of adhesions which may be present, and there is sometimes deep infiltrating endometriosis as well. Then sometimes there can be a premature ovarian insufficiency, which means that a patient who is less than 40 years of age will stop having her periods. That is also becoming fairly common in the scenario globally. Then, of course, we do know pelvic adhesions are also one of the causes for infertility and cancer treatment, especially where there has been some treatment of either the uterus or there is a treatment of the ovaries that has happened. So all these are some of the causes of infertility. Now, what are the absolute important tests which have to be done prior to actually going ahead for an IVF or even an infertility treatment? Which means when a patient comes to us with infertility, one of the most important tests which will be required is a transvaginal sonography. And it is always preferable these days to do a three-dimensional transvaginal sonography. However, if it is not available, even a normal transvaginal sonography with a good resolution will help us. So what that tells us is what is the uterine size and shape? What is the thickness of the endometrium? Are there any abnormalities, like are there any submucous fibroids? Are there any polyps? Are there any adhesions? And also, what is the ovarian volume and the antral follicle count? So ovarian volume is a very important test, which just tells us what is the ovarian reserve that is present, and so is the antral follicle count. Now, as we all know, this test should be done on day 2 or day 3 of a patient's periods, and it will tell us. So what the radiologists do is that essentially, or what we do is essentially count the number of follicles which are present in each ovary and also estimate the ovarian volume. Now, ovarian reserve testing. Now, of these, some of the important hormonal tests are the follicle stimulating hormone, the estradiol, the anti-Mullerian hormone, which is the AMH. And we also know that very high levels of FSH may affect the results of IVF. So FSH is an important test, which has to be preferably done on day 2 of the periods. But if the patient is not having regular periods, it can be done at any point of time. AMH levels tell us about the number of eggs which are available. As we all know, every woman is born with a definite number of eggs. And as the years go by, as she grows older, the number of follicles are definitely going down, the number of eggs are reducing, and the biological clock keeps ticking. Now, nowadays, we are also finding that AMH levels are extremely low in a lot of people. Younger people also have very low AMH levels. We're also finding that people are getting married late. They're thinking of conception much later. So AMH levels have also gone down to a sizable amount. Now, apart from this, one of the other tests which is required to be done is a tubal patency test. So a tubal patency test is a hysterosalpingography. In a hysterosalpingography, we just push in a radio-opaque water-soluble dye through the uterus. It goes through the uterus, comes out through the tubes, and we find out if the tubes are open or not. We are seeing this on a fluoroscopic screen, and we take x-rays of the same. So that is a documentary evidence which tells us if the tubes are open or not. And as I told you, one of the commonest reasons for doing an IVF is blocked tubes. A similar procedure is called a sonosalpingogram, in which we are using an ultrasound and we push saline into via the cervix into the uterus, and then we are seeing that there is fluid which is collecting in the pouch of Douglas. So it's a similar procedure which tells us if the tubes are patent, open or not. And of course, in case for some reason we have to do a laparoscopy, along with the laparoscopic procedure, which is a diagnostic procedure, we can even do a chromoperturbation. A chromoperturbation essentially means that we put in a dye, which is a methylene blue. We are visualizing everything through a laparoscope, and then we are seeing if the tubes are throwing out this dye or not. And we directly get to know whether the tubes are open or whether they are not patent. So these are the tests for tubal patency. So these are the bare essential tests which have to be done. One with regards to the tube, one with regards to the ovulation, and the third thing, of course, is to check for any uterine problems via a sonography. Now, I don't know what the scenario there is, but here, a lot of times a patient will come to us with infertility, but the husband refuses to get checked. He says, I am fine, my wife has a problem. For some reason, he does not want to get tested. So it is extremely important to know that about 33% of infertility is caused because of the female partner, 33% is because of the male factor, and 33% is because of both of them combined. So it's very essential that we press for a semen analysis or a semen evaluation. Now, this test is preferably done after 2 or 3 days of abstinence, and the results will depend upon whether a complete sample is collected because of the activity of the accessory sex glands also, and the size of the testes as well. So the procedure is a standard procedure. It is done after 2 to 3 days of abstinence. It is done in a private chamber where the man can masturbate and collect the semen sample, and immediately it can be given to the lab. Suppose that is not possible, then he can collect it at home, but within 15 minutes or so, he should get it to the lab. Most good hospitals and labs, however, do have semen collecting rooms that are available. Now, this is a picture of the WHO, recommendations of what a normal semen analysis is. So things have changed a lot since 2010. 20 is whereby, some of these per 10 to the power of 6 per ejaculate. Motility should be 42%. So in 2010, it was said it should be more than 40. Now it says 42%. Progressive motility should be about 30%. Non-progressive motility should be about more than 1%. And if there are immotile sperms, they should be less than 20. And vitality, of course, we know it should be around 54%, and normal morphology should be about 4%. So anything which is out of this which has been recommended as a normal semen analysis does require evaluation. And a lot of times we do refer them to our andrologist friends who treat this male infertility. And one sample is actually not necessary to label something as oligoteratozoospermia, etc. But we require at least 2 to 3 samples which are spaced at different points of time before we actually say that this husband semen test is abnormal. So it tells us the liquefaction should happen within 30 minutes. The viscosity of the semen, if it is too viscous, it may imply that there is some infection. What is the ejaculate looking like? What is the volume? What is the pH? What is the motility, the vitality, the absolute numbers? Are we seeing a lot of pus cells in the sample? Are they immature germ cells, which are again signifying some infection? So all these things will need to be delved into, and we need to actually make sure that, you know, there is either the semen sample is good or it's not really good. Then we have some important infectious disease tests which also need to be run before an IVF procedure, or even before we take the patient up for some kind of surgery. So we do require to get the viral markers like an Australia antigen, and HIV testing, HCV, VDRL, and where indicated, even a complete STD panel should be done. And of course, we all know that a basic evaluation of the blood tests as well as the urine tests has to be done, because, you know, it's important to see that the patient is not anemic. We get a complete blood count to make sure that there is no diabetes or deranged blood sugars, and HbA1c should be done. The thyroid test should be evaluated. Before we actually delve into a pregnancy, we should also know about the rubella status of a patient. We should also know about things like thalassemia status, sickle cell anemia. So all these things should have been evaluated before we actually jump into an IVF, or before, you know, as part of the infertility workup. Vitamin D levels are very important. Iron studies are important. So a generalized blood test as well as urine tests are also required before we actually go in for the infertility treatment. And here is where the role of our GPs also comes in, because, you know, most times we do get patients who've been completely evaluated by our practitioner friends, and we find that we just have to do the surgery as such. Now, after we determine whether the patient is, what is the problem that the patient is having, now we come to some of the corrective surgeries which are required prior to an IVF. So I am just going to delve into some of these procedures, and whether, you know, all of them require surgery or whether they don't require surgery, and which patients should be referred to us for these corrective surgeries, because a lot of these surgeries are going to be done and they are going to determine the procedure, whether it's going to be successful or not. So the outcome of an IVF will determine a lot on some of these corrective surgeries as well. So first of all, we all are dealing with this problem of fibroids. And fibroids, as you all know, are the submucosal fibroids. The submucosal fibroids are those which impinge into the cavity of the uterus. So these are the ones which are going to interfere with the implantation. Sometimes we also find that infertility may happen if there are fibroids which are blocking the cornual ends of the uterus, which is the tubes are completely blocked because of these fibroids which are present at the cornual ends of the uterus. Then, of course, there are some fibroids which are also forming a kind of a polyp inside the cavity of the uterus, which are called as the submucosal fibroid polyps. So submucosal fibroids definitely will require to be enucleated and removed. Now, the second thing is that we do have some intramural fibroids as well. The intramural fibroids are present in the muscle layer of the uterus, as we all know. And sometimes they may be partly present in the muscle layer of the uterus, and partly they may be present in the impinging inside the cavity, and some partly which are on the external surface as well. So these are the intramural fibroids. Subserosal fibroids are those which are present only on the external surface of the uterus, and they have nothing to do with the cavity of the uterus. Now, the FIGO has given us a good classification as to, the classification of fibroids starting from 0 up to 7. Now, the fibroids, which are actually inside the cavity of the uterus, or the large intramural fibroids, which are again going into the cavity of the uterus, will definitely require adhesion, and we will need to remove those. But purely subserosal fibroids actually do not require treatment from the point of view of infertility. Yes, if they are very big fibroids which are causing other symptoms like pain or pressure symptoms like the bladder symptoms, or they are causing the bowel symptoms, then definitely that's another reason. But purely from the point of view of infertility, we do not need to remove pure subserosal fibroids. So definitely submucosal fibroids require to be removed unless they are extremely tiny, and intramural fibroids also require to be removed if they are again impinging inside the cavity of the uterus, unless if they are extremely tiny and they do not require removal. Now, this is just a picture which is showing the pedunculated fibroid. Like I told you, in case there is a pedunculated fibroid, it has to be removed because this is going to interfere with the implantation of the baby. Then, apart from that, a submucosal fibroid, which is impinging into the cavity of the uterus, will again require removal. An intramural fibroid, if it is small and it is only present in the wall of the uterus, may not require to be removed. But if it is reasonably large and a part of it is also impinging inside the cavity of the uterus, we need to remove it. A pure subserosal fibroid, which is only on the external surface of the uterus, will not require to be removed for the purposes of fertility. So these days we have two kinds of modes of removal of these fibroids. So one, of course, is the hysteroscopy. Hysteroscopy, we remove the fibroids which are essentially inside the cavity of the uterus. So anything which is like this pedunculated fibroid, or if it is a submucosal fibroid, can be removed hysteroscopically. But fibroids which are more towards the external surface of the uterus, or there is mainly an intramural fibroid, can be removed laparoscopically as well. Sometimes we require a combination of hystero and laparoscopy to remove these fibroids in totality. And once these fibroids are seeded out of the uterus, then they can be morcellated as well. Morcellated means they are broken into smaller pieces and then they are removed laparoscopically. So there are very interesting procedures on how we do this hystero and laparoscopy for removal of fibroids. Now we come to the endometrial polyps. This is a hysteroscopic picture of a large endometrial polyp. As you can see, it is completely impinging the cavity of the uterus. So obviously, where is the pregnancy going to implant itself? We are going to remove this the endometrial polyp, and this can be done hysteroscopically. And then, of course, we send it for biopsy and testing just to get to know what is the kind of polyp which is there. And of course, sometimes we have all heard of Asherman syndrome. Asherman syndrome happens when there are intrauterine adhesions. This could happen when there is a DNC which has happened, or also because of some infective conditions like tuberculosis, which is quite rampant in our countries. So when there is excessive curettage, which is done, for instance, for an abortion or a DNC, it is going to destroy the normal endometrium, and because of that the walls just get stuck to each other, forming these dense adhesions. So this is called as Asherman syndrome. And if Asherman syndrome happens, we get to know because there will be very less flow during the menstrual cycle, or it may completely stop. And then we do get to know when we do an HSG, or we get to know with a good 3D ultrasound and Dopplers, we get to know if it is completely stuck and there are adhesions which are there. So these adhesions will also require to be removed by a process which is the hysteroscopic adhesiolysis. And following that hysteroscopic adhesiolysis, either we put in a Foley's catheter for some time, or we also require to give estrogen and progesterone to make the endometrium regenerated. So here in this case, definitely we do require to remove this polyp, and sometimes intrauterine adhesions will also require to be removed hysteroscopically. Now, this condition, which is endometriosis, is a condition which is quite a bane for both the physicians, the surgeons, as well as for the patients, because endometriosis is a lifelong condition. This basically means that there is endometrial tissue which is present outside of the uterus, and it can begin with very mild kind of endometriosis, which means just some endometriotic spots which are present, or there could be some cysts, which are the endometriotic or the chocolate cysts which may be present in the ovaries. Or we also have very severe endometriosis, which is the deep infiltrating endometriosis, whereby all the organs are completely stuck to each other. The pelvis is completely frozen and the gut is involved. Sometimes the bladder may be involved. The ureters may be involved in this. And the whole anatomy is completely distorted. Sometimes endometriosis can also be present in distant sites, for instance, like even the lungs, the brain, etc. But these are all uncommon conditions, but endometriosis within the pelvis is a fairly common condition which we are finding these days. So in case there is endometriosis, we definitely do require to correct that unless it is very mild endometriosis. So if there is very mild endometriosis, we do not want to do a surgery, lead to more scarring. It is always better to resort to that in case there are endometriotic cysts which are present. In case we find that the ovaries are stuck to the uterus, or in case we find that there are too many adhesions which are completely blocking the tubes, or which are which are completely distorting the anatomy of the pelvis. So when we do a procedure like an operative laparoscopy, which is done for endometriosis, either we just do a cystectomy, which means that we are removing these chocolate cysts of the ovary. The very important thing is that whenever we do this procedure, we must make sure that there is healthy ovarian tissue as much as possible, which can be left behind. Because if we destroy the normal ovarian tissue as well, it is going to lead to decreased AMH and decreased chances of success of an IVF as well. So what we do is we try to remove only the cysts which are present, which are the chocolate cysts. We try and use as little cautery as possible so that there is functional ovarian tissue which is also left behind. Sometimes, we may even require to do an egg freezing before we actually start this process of removal of the endometriotic cysts. So endometriosis, basically, we may require to remove these ovarian cysts. Sometimes an adhesiolysis may be required, which means we remove the adhesions so that we try and restore the anatomy of the pelvis, because that is very essential for the success of an IVF. Then we also need to see and document the condition of the tubes, whether the tubes are open or not, whether they are closed or not. And Sometimes when we do this procedure, if there are other endometriotic spots which are present in the pelvis, those can also be ablated, because these endometriotic spots do have some inflammatory chemicals, or these will interfere with the success of an IVF as well. So these are some of the reasons why we do an endometriotic surgery. Now, sometimes we require to do some tube related procedures. Sometimes we find that a patient has got a tubal ligation done because her family is completed, she's had a tubal ligation done, but there's some problem which comes with the children, and then she requires to get it opened up. And that is basically, we may require either a tubal reanastomosis, or which is called tubal recanalization procedure. Sometimes we find that the tubes are very badly damaged, and there are more chances of an ectopic pregnancy if we leave those tubes behind. So we may require to do a salpingectomy or a removal of these tubes as well. Sometimes, if both the tubes are badly damaged, it is again important to do something which is called a tubal clipping, which means we just clip the ends of the tubes and we delink it from the uterus, so that these tubes do not keep on passing toxic material inside the uterus, which will decrease the effect, or which will actually decrease the success of our IVF. So we may need to do a tubal clipping as well. Sometimes only the fimbrial end of the tubes are blocked. So we may just require to do a fimbrioplasty, which is a fairly simple procedure. If we find that the uterine end of the tubes are actually closed, then through a hysteroscope, we can put in a cannula and we can do a hysteroscopic cannulation of the tubes, and we can open the tubes like that. So these are some of the tube related procedures which may be required. So, when we do a diagnostic procedure, we get to know which part of the tube is actually damaged. If it's looking like the cornual end, we can attempt doing a hysteroscopic cannulation. In case we find that the entire length of the tube is badly damaged and it's going to serve no purpose, in fact, it's going to be counterproductive keeping that tube, then of course we can do either a salpingectomy or we do a tubal clipping of the tubes, so that our IVF success rates definitely improve. Now, we have all seen some uterine anomalies as well. Now, do all uterine anomalies need to be corrected just for the purposes of fertility? So the answer is no. Most times, if you have there are various kinds of uterine anomalies. If you have a septate uterus, then definitely this is something which will require correction. If we have an arcuate uterus, which means there is a very minimal kind of a dimple which is present when we examine it from the laparoscopic fundal aspect of it, that does not require to be removed. In case we have a bicornuate uterus, which means there are two horns of the uterus which are causing too much of a pain to the patient, or if the cavity is really small, then there is a process which is called as a Strassman procedure, in which we can basically remove that and we can just sort of open up the cavity and just sort of link these two horns together. Then in case there is a rudimentary horn which is present, sometimes we find that there are two horns, one which is the main. If there is a rudimentary horn which has some amount of endometrium, which is actually causing more of a pelvic pain and which is leading to the endometriosis, then that also may require to be removed. But a lot of times we do not require to remove all these uterine to correct these uterine anomalies. And we also need to remember that sometimes uterine anomalies are associated with renal abnormalities, they are associated with cardiac abnormalities and also vertebral abnormalities. So sometimes these surgeries can be tricky surgeries, And we have to be very careful about which ones to actually do, and which ones, will be better off without doing a surgery. But definitely septate uterus is something which will require to be corrected. Now, from a GP's perspective, I'm sure, a lot of wonderful friends of ours do already have this whole protocol of how exactly to kickstart the treatment journey of a patient. Because most of the times, like I said, a lot of people have more faith in our GPs, and they would first go to their preferred, GPs become more friends than doctors. So they first go to the GPs and they will talk to them about whatever problems they have. A lot of times, all we require to do is, we already have a completely worked up patient, and all we require to do is just to sort of take it from there. So how can you actually kickstart the treatment journey of infertility? So first of all, of course, the history of the patient is important, an examination and some general blood tests, etc., which have to be done. Endocrinal disorders, of course, if there is something like that, it will need correction. And a lot of times, like I said, we rely on our GP friends to correct those abnormalities like thyroid abnormalities. A lot of times PCOS may require correction. A lot of times there are hyperprolactinomas which may be there. Then, of course, the rubella testing, which needs to be done. We need to do an infectious disease testing, an HPLC test to test for thalassemia or sickle cell anemia. The AMH needs to be done, which means for ovarian reserve. A transvaginal sonography, if you could order, that would be wonderful because it makes our job very easy. And MRI where it is indicated, because if suppose you don't have a three-dimensional TVS, or sometimes the TVS patient is not very comfortable with the TVS, or sometimes we have unmarried girls who come, an MRI may be required there. Of course, a husband semen analysis will be required. And in case there is anything which, is looking like it could require surgery, or it could require a gynecologist's intervention, then of course, a referral will go a long way in helping our patients to be treated in this huge problem, which is that of infertility, which is rising all the time all across the world. So thank you so much for the patient hearing. And in case there are any questions, etc., I'll be very happy to take them.
Yeah. I request that you may have a lot of questions for Dr. Shelly. You can directly ask, unmute yourself and ask, or you can type in the chat and Dr. Shelly will address those. Ma'am, please give us 1 or 2 minutes.
No worries. Please take your time.
So, Dr. Gadaga, Dr. William Gadaga, any questions? Dr. Hewitt? Yeah, okay. So there's a question from Dr. Dinawal. So the question is, should we go to hysteroscopy plus laparoscopic chromoperturbation or repeat HSG for a patient diagnosed with bilateral proximal tubal blockage by HSG?
Yes, so that's a very good question. A lot of times what happens is when we are doing an HSG, all the time it's not being done with sedation. So the patient has kept herself so tight that there is appearing to be a tubal spasm, there's a tubal spasm which is appearing to be like a bilateral proximal tubal blockage. So one good hack is that the patient should be given some anti-spasmodic before we do this procedure. If we can do it with a little bit of a sedation, that also goes a long way, because after all, it is a painful procedure. But then, so that will, to a large extent, remove the false positives of proximal tubal blockage. But in case it is appearing to be a proximal tubal blockage and you're seeing that both the tubes are appearing to be blocked, I feel that it's better to go directly in for a diagnostic hysterolaparoscopy and to do a chromoperturbation, because that we're directly visualizing that. So most patients find it very painful to get an HSG done again and again.
Yeah. Let's wait for any other questions. Okay, so there's a question for Dr. Al Mustafa Nuruddin. His
Yes.
question is, first, it's a compliment for a very elaborate presentation. He has two questions. So, what
Yeah.
is the success rate of the procedure? Dr.
So
Mustafa, can you specify which procedure, or are you talking about IVF? And the second question is, what is the cost implications? Now, let's assume that he's talking about IVF, so
okay.
you can answer from there.
So success rates of IVF procedures in good centers here are now in the tune of around 60% or so. And the cost implications would be, it depends upon the kind of IVF procedure which we are doing. A lot of times, you have to do either an ICSI procedure, or we have to do, basically, sometimes we require donor eggs, sometimes we require, it depends on the kind of the IVF procedure that we are doing. But it would be in the tune of around 3 to 4 lakhs. Starting would be about 3 to 4 lakhs.
Okay, so in dollar terms, ma'am, that would be around $3,200 to $4,500 per cycle, right?
Yes.
Okay. Yeah, Dr. Mustafa was talking about IVF only. Now, there is a question from Dr. Sunday Oge. He's from Nigeria. Again, compliment. Thanks for the presentation. And his question is, could you explain more on the size of the fibroid that must be surgically removed? And he has a follow-up question on that topic only, and then medical management of fibroid generally.
Yeah. So, Dr. Sanjay, the thing is that we don't have a specific size which is taken as the benchmark that this has to be removed. Even small fibroids, suppose they are causing a corneal blockade, or even small fibroid polyps which are there, will require to be removed. But anything which is bigger than size-wise, of course, where it actually is approximately 12, equivalent to 12 to 14 week size of a pregnant uterus, which means it's a very large fibroid that definitely requires removal. But small fibroids also, where they are causing a problem, like submucous fibroids, polyps which are there, will definitely require to be removed.
Okay. Now, there's another question from Dr. Dinawal. He asked a previous question, and he's from Ethiopia. So, what about the status of uterine lining, especially after correction of uterine-related infertility before we go to IVF?
Right. So basically, the uterine lining should be, we should have a good plush lining which is available. And if it is not a very good lining, we have medicines which can make it a little plush. Especially as I spoke to you about intrauterine adhesions, recently we had a case whereby, she had missed abortion, and she had got a suction evacuation done, and they did a curettage. This was in another country, and it was full of adhesions. So when we tried to at least find out what was the endometrial thickness, it was not even 1 millimeter in some parts. It was really, really very, very thinned out and completely scarred, and all the walls completely stuck together. So then we did an adhesiolysis, and then we gave her medicines like a combination of estrogen and progesterone, so that estrogen just helps us to regenerate the endometrium. So we have ways in which we can regenerate the endometrium, but of course it depends from patient to patient. A lot of times, if the scarring is so bad, we may not even be able to generate that kind of endometrium. So it depends from patient to patient.
Ma'am, I think we missed the answer to the second question of Dr. Sunday, which was around medical management of fibroid generally, like which do not indicate
So
surgical
yes,
intervention, but
yes.
medical management.
Yes. So these days, most, I don't know about that side, but here, there are a lot of people who are talking about elagolix. Elagolix basically is a GnRH antagonist which is there, and that is of course being also given for the shrinkage of of these fibroids. So we do give that in case it is required. We have the GnRH analogs, also the GnRH injections like Lupride, etc., which can also be given. The GnRH agonists are also being given these days, the elagolix, which is also being given. So all these things are there. Then we also, they basically help us to reduce the size of the uterus, but most of the fibroids. But a lot of times, submucous fibroids will not really respond to medical management. And these are the main culprits which are, responsible for producing infertility.
Okay. So, ma'am, there is a question from Dr. William Gadiga.
Yes,
He's the GP practicing in Zimbabwe.
yes.
So his question is, after a myomectomy, what is the
Yes.
minimum period before conception?
Right. So we generally say that at least 3 to 4 months of contraception should be used, and we should not have a conception happening in the 3 to 4 months, because a lot of times there is, when we've done suturing of the uterus, sometimes, although we try very hard not to open the uterine cavity when we remove these fibroids, sometimes even that happens, because if it's a large fibroid, it's completely indenting inside the cavity, or if there is a hysteroscopic myomectomy that's being done, then definitely there, these areas are the weak areas on the uterus, and we say that it should be given enough time for healing, which is 3 to 4 months after the surgery.
Okay. Ma'am, in this light, I would request you to elaborate, because many times doctors and GPs, they struggle with managing patient expectations, as the marketing driven, advertising driven world would make promises like 90% success rate, 100% success rate, which could be in a very, depends on what methodology and what data set they're excluding. But real
Right.
scientific evidence is, even in the best facility in the world, 50 to
Yes.
60% is considered excellent chance.
Yes. Yes.
So if you
In
could
fact,
elaborate
here,
on that.
yeah. In fact,
Yeah.
here in the
So
very good centers, it is about 60 to maximum 70%. But we have moved from the times when it used to be like about 40 to 50%. But with more robust protocols that we are using, with more robust medication that is available, injections which are available, but nobody can guarantee a 90 or 95% success rate. It's not known anywhere in the world, not even in the countries of the West.
okay, so ma'am, my question was like, many times GPs or doctors, like, I mean, in India also we face this problem. Anybody, any influencer may come, and like we had this controversy around Live 52, which when I was a kid, I mean, oh, he doesn't eat much, give Live 52. Later research shows that it actually damages liver. So many times, doctor community anywhere in the world, they face this challenge where marketing speak, communicates and sets expectations, and doctor's challenge becomes counseling the patient with the reality. Look, what they are talking
Yes,
is not possible.
yes,
If you could spend some words like how they should, when they face these things, how they should counter, because they have this challenge of, making a normal person understand medical science. So
yes.
if you could
In
just,
fact, Varun,
yeah.
add to all this is Google, because Google is making things so difficult for us. Influencers on Instagram, they tell us a different story, and people are most willing to listen to them and to Google rather than the doctors. But then it is through consistent counseling, we should be their friends, we should just tell them about all the pros and cons, we should tell them that, you go into this literature, read a little more, this is what this is what is my experience. So very patiently one has to go forward, but only thing is that whatever we say must be backed completely with our protocols, with our RCTs, with all the trials and whatever is the guidelines which we follow.
I think, ma'am, that's it. There is no further question. And if a question comes up, I mean, we have working groups with all of the doctors. If question comes up, we will share it with you.
Sure, and I'll
And
be happy to answer that.
yeah, just as a ending note, ma'am, another problem which is in cross-border, because I mean, our African doctor colleagues, they operate in very challenging and resource variable environments, and because many times solution do not exist there, so sometimes agents step in, guiding, or rather misguiding or selling hope and dreams, not scientific ones, to the patients.
Yes,
So if you can
yes.
speak about like these dialogues, like between you and your colleagues in Africa, and these structured pathways, if as a doctor practicing here, seeing everything, if you can speak a few words like how this is better, like how them guiding is better with support of Indian specialists than an agent guiding a patient. And ma'am, it's been a lot.
Yeah. So in fact, that is a challenge which we are also facing here, because you have agents who ask the patients to come here, and first of all, it's possible that it should, treatment is not really required, or there is a much extensive treatment which is required. They will just tell the patient that this is what needs to be done, and I'm sure this will be 90-100% results will be there. So there are all kinds of, which are basically being driven by the materialistic aspects of it. And of course, we are all from that community where each one of us, of course, has to make money as well, but only thing is that we have to practice ethically. And a lot of times what will happen is that they will pressurize you into sort of, the patient has come here for a surgery. You may also find that you said that this does not require surgery, but then you find in the same hospital there is someone else who's doing a surgery. So all these things are making things a little difficult, I think, across the world. But I do feel that anything which is doctor driven, especially if we've had this kind of a communication, or if a doctor communication happens, and if there are people like what you are doing, where you're sort of making a conduit between doctors, it will go a long way, because then it is going to lead to more ethical and better result practice as well, rather than just jumping into this thing. Patients are spending so much money coming to different places in terms of medical tourism, and suppose one is, it does not require surgery, or we are not able to give those results. That's not really fair on the patients. So I feel what you're doing
Okay.
is a more scientific, and it is a more sort of medical to medical thing, which is not so governed by people who are there only to make money.
Okay. So now, ma'am, we have two follow-up questions. So there's from Dr. William Gadag again. He requesting to repeat the average cost of IVF.
So that is
Ma'am, can you
about
break it down like first cycle and okay, two scenarios, ma'am. Like one cycle, the first cycle, and let's say first cycle does not succeed, the parents or the couple still stays, and
so
subsequent cycle.
But surgery will be different, because different kinds of surgeries and different, how extensive the surgery is, and all of that will actually determine the kind of surgery which has to be done, and what is going to be the package for that surgery. But IVF, in terms of Indian rupees, I'm sure you will be able to
I'll
give
transfer.
us better. Yeah,
Got it.
you'll. So it is approximately, the first cycle would be about 2 to 3 lakhs, and subsequent cycles, sometimes we just need to do, we just need to do an ovum transfer, or we have the embryo which are frozen. So all those things subsequently will be less. So about 3 to 4 lakhs would be the cost of an IVF. Surgeries, of course, depend upon what kind of surgery is required, how extensive it is, and also to a large extent, here it is also dependent upon the kind of hospital that you are in.
Okay, Dr. William, like it's a very variable, patient to patient dependent. Somebody may need surgery, somebody may not need surgery. Doctor said about first cycle 2 to 3 lakhs. 2 to 3 lakhs is about 2,300 to 3,000 600 700 USD. And overall, like if a subsequent cycle is required, the treatment cost reaches 3,200 to 4,500. Those are the costs. And there's a question for Dr. Hewitt. So first compliment to you, ma'am. Dr. Hewitt is from Ethiopia. So she compliments you on the excellent presentation. And the question, very important question, ma'am. And here there's a lot of regulation, and many times we have seen hospitals on the safety. So is there an age limit for women to go for IVF at your hospital? In India, it is
So
55, but at your hospital.
yes, yes. No, it is not really our hospital now, because there are a lot of guidelines which have been laid now by the government of India also. So the government has laid some guidelines according to which post 50 they are a little, for women post 50 is a little, is taken as the cutoff. But up to about 55 years also is what is being allowed, because we used to have people who were at 60, 65 also getting IVF done. And then of course there comes the ethical, the concept of who will take care of the children, etc. So that is the reason why it has now been, if we go strictly by government guidelines, it is 50 for the woman and 55 for the male.
Okay. Ma'am, about, I mean, if you, like surrogacy is not allowed in India, permitted, or at least for
Yes,
foreign patients. If you could clarify,
yes,
because Turkey is the better destination for that case, if there is a patient. If you
yes.
could specify the guidelines and rules around, let's say, egg donor or sperm donor, those kind of conditions, ma'am.
Yeah. So surrogacy is not allowed in India because here again there was a lot of problems which were being faced by the surrogate mothers and also by the biological parents and all that. So they've made surrogacy illegal here in India now. But oocyte donors are available, and oocyte donation, of course, depends on the kind of donor that you would want, because there are various, depending upon the kind of donor that you want. Yes, you have different donors and different donor. The packages also vary according to the kind of donor. So you may have donors who, in a lot of ways, are like you. So it is a kind of a matched kind of a thing with physical characteristics. You make sure that there is no problem, no medical problems, no genetic problems, but we do have oocyte donors who are available here.
So, ma'am, we had a case, like it was Fortis La Femme was, did the consultation. So it was a single woman. Legally, it was allowed because law allows single woman as the commissioning couple. But then there was a question around donor, like sperm donor or egg donor. There were many challenges in that case. There was no viability. But just to clarify, ma'am, many times people have a question, let's say if somebody of African ethnicity, they would want to question whether either oocyte or sperm, like whether donors or those eggs or sperms are available from those ethnicity. So
Yes.
is that
So
possible
we
here
do
in India?
have those, yes, they are, we do have those also available. There are, sperm banks, there are, the various donors who are available. So a lot of times if we have some patients who would require the, same race kind of a thing also, they are available.
Okay. Now, ma'am, there's a question from Dr. Lillian Jesse. Again, compliment to you for your presentation. And her question is, how long does it take for an endometrium to completely regenerate following estrogen and progesterone therapy?
So, Dr. Lillian, what basically we give it for a period of around 3 months or so. So, what we do is after we've done the adhesiolysis, we give a combination of estrogen and progesterone. So, estrogen, which is given throughout the cycle, and in the last 14 days, we just add the progesterone. And it takes about 3 months or so for the regeneration to happen. So we do a transvaginal sonography for endometrial thickness before that, and post those 3 months also we do we do a transvaginal sonography to see how well it is regenerating. So we give it a time of about 3 months before it regenerates. But most times we will find that even after about a month and a half or so, it starts to get better. It starts regenerating where the scarring is not really bad, and where, you know, the adhesions are not so bad that they have permanently damaged the endometrium.
I think
Thank you.
there's no further question, Dr. Shelly, with your permission, and I would really like to thank you for your time. And thank you, Dr. Shelly. It's your son's birthday, and still, on our request, you took time out for this.
Thank
And
you so
I really appreciate, ma'am. And about Dr. Shelley's background, she is a graduate from two of the top medical universities, colleges in India. One is Maulana Azad Medical College, only the top students go there, and Lady Harding Medical College, where she did her master's. And thank you, ma'am, and thank you to all our Jivo doctor partners from Africa. I know how precious Sunday is to everybody, probably the only day and time with their families. Thank you all. And if there are any follow-up questions or any case that you want to discuss, please inform us in the Jivo Doctor group. We'll direct it to Dr. Shelley. And it's not only about a patient referral. If you, many times patients don't have means, but if you face any patient struggling and you want some clarity, you can write a doctor to doctor note addressed to Dr. Shelley, and I'm sure she will be happy to respond and guide you how you can manage it locally. Thank you, Dr. Shelley.
Definitely. Thank you so much, Varun, for organizing that. And thank you so much to all my doctor friends for for spending so much time on a Sunday afternoon.
Thank you, ma'am. And there is again, okay. Thank you all.